Malingering, of course, is a different type of disorder. Let's review the case. A 40-year-old homeless man presents to the hospital on a cold night, complaining of auditory hallucinations, telling him to kill himself. When asked about his past psychiatric history, he is unable to give any detailed information. He seems concerned about being admitted immediately and refuses all medications when offered. This is classic of patients who have malingering. This is the individual who fakes their signs and symptoms, but there's an obvious gain. For this individual, the gain was getting into the hospital. Why? Because it was cold and he was homeless. If you notice in the question, he didn't care about the medications. All he cared about was being admitted. So patients who have malingering, their main focus is getting something out of the situation. These are the disability cases. These are the patients who are in traffic accidents and they claim whiplash injuries. They know what they're doing and they know why they're doing it. So there's nothing here as far as unconscious intent. These are people who do not have a mental illness, and that is why malingering is never considered a mental illness or a mental disorder, because if you know what you're doing and you know why, you therefore are not mentally ill. You see a lot of these disorders in men that are in prison, for example. They'll claim to have abdominal pain, so they get sent to the hospital ward instead of being in the regular population. People in factory with disabilities, and of course in the military. If all of you remember the show MASH with Klinger, what would he do in that show? He would always pretend to be mentally ill. He would always wear women's clothing. Why? Because he wanted the army to think that he was mentally ill. But everybody knew what he was doing. He knew what he was doing, so there was an obvious gain, and that's what you find in malingering. Now, most of these individuals do express subjective symptoms. They do tend to complain a lot, and of course, there's the massive exaggeration of their symptoms, and they're more preoccupied with the rewards than with the alleviation of their symptoms. So if you were to have a pain patient who complains of all this horrible pain, and you're wondering whether they're malingering for getting to get their drugs, and you were to say to them, you know, there's a new procedure where I guarantee your pain to be reduced in 99% of the case. What do you think this patient will say? They'll probably say, you know what, 99% doesn't cut it for me. Give me my Demerol, give me my Soma, give me my Vicodin, and when you come up with a procedure that's 100%, then maybe I'll think about it. Because all they care about is getting the drugs and not necessarily in the alleviation of the pain. And the treatment, it's either referring these patients to the legal sources or basically allowing the physician-patient relationship to work. Many of these times these patients do get criminally prosecuted because these are situations where fraud is involved. Now, the biggest differentials from a psychiatric point of view will be a somatoform disorder. Let's go back to this basic table looking at somatoform, factitious, and now adding malingering to it. If you look at the issues for malingering as far as symptom production and symptom motivation, what do we find? We find that most of these patients are conscious. They know what they're doing. They know that they're the ones producing their signs and symptoms, and they know why they're doing it. So that is the difference between all of three disorders, and the only one that is purely psychological, of course, will be the somatoform disorders. Let's look at a question. A 40-year-old woman presents to your office and demands to be seen immediately. She schedules appointments to see you on a regular basis as well as irregularly. She routinely goes to the emergency department when she knows you are in the hospital. She calls your service every night and demands that you call her at home. Her frequent complaints include headache, shortness of breath, double vision, burning at urination, weakness in her arms and legs, and tingling in her fingers and palpitations. Because of all the multiple organs and all the multiple symptoms, we know that this patient has somatization disorder. But the question is, what is the next step in the management of this patient? How do you handle patients with this kind of disorder? Do you A, tell her it's all in her head? Do you B, assure her there's nothing wrong with her? Do you C, refer her to Psych? D, begin a trial of lorazepam? Or E, schedule regular office visits? If you recall, the treatment is monthly visits, brief in nature. You have to continue to treat her and slowly basically tell her where the real problem lies. So the best answer for this question is letter E.